Today we've been called to a 70-year-old male who's had a complaint of chest pain, has had a collapse. He had an acute onset of chest pain and it felt like his heart was going to pop out of his neck, and pain kind of going up into his neck as well. He had a history of an MI 5 years ago, but he does say it had felt different today. Presenting pale, clammy, does open his eyes into voice, however he's not responsive, unable to obey commands. Patient's medications is cilazapril and aspirin. So I've come into the scene. Hello sir, can you hear me? Hello? He's opening his eyes but he's not responding. Can you tell me your name? Not responding. I'm just going to have a feel of his pulse. It's very tacky, so I'm just going to put on the leads and to get an idea of what the rhythm is. With this mannequin, you also have to put on your pads to get the true rhythm, what's going on. And looking at that initial rhythm, I'm looking at a VT at a rate of 182. I'm going to just get that printing and get onto the radio and get an ICP backup. Target 1 to North Comms. Yeah, I just need to have an R50 for a patient that is in VT, conscious VT, and requiring a cardioversion. Thank you. So backup's going to be here in 10 minutes, so we're not going to wait. So I'm going to now get a set of vitals quickly. Find out the blood pressure he's very compromised, severely compromised. Blood pressure is at 70 systolic. Rest rates are normal, but he is in VT. So I'm going to progress now looking at what are my differentials, what possibly could be else going on. Hypoxia B1, obviously rest rates are normal, so it's not likely he's hypoxic. Electrolytes, could be some imbalances. We don't have enough history to find out if that potentially is the problem. Drugs, digoxin could be a potential risk, or cocaine, not likely. Our 70-year-old male with a cardiac history most likely is prone to have a VT due to a cardiac event. So the other thing I would be looking at is, as I printed out the 12 lead, I'm looking for ECG fusions and also showing capture points on the ECG, which I don't see any, that there's no bundle branch block associated with this VT. So I'm presuming now that it is a normal VT, and I'm going to go through my checklist for a cardioversion. So I'm taking out my checklist. I place the pads in the apex and sternum positions. I've ensured the defibrillator is in manual mode, looking at my energy. I'm in manual mode at maximum joules. Next, I'm going to then select a lead where I've got a visible points on the Q waves. So I'm putting into sync. And there we have our markers on the tops of our waves. So we are in right position, right placement, right lead. So it's been, I'm ensuring that the patient has adequate sedation. Because our patient is severely compromised, there's no need for any further sedation. So we've selected the joules. We know it's at maximum joules. I'm confirming that everybody's clear. Everybody clear, and at that point I would be charging to maximum. It's fully charged, holding in the shock button until joules are energy is delivered, and our patient is now reverted into a normal sinus rhythm. I'm going to print that out. Now if my patient had not reverted, I would check for a pulse to see if he is pulseless. Obviously we're into a normal resuscitation and not a cardioversion. And we can give one more shock if required to cardiovert. Finished.